ways to be able to break chains of transmission, including making sure we find those cases that we know about, we find all of their contacts, and we quarantine those contacts. And by doing so, you effectively isolate people so they can't pass the virus to someone else, whether they have symptoms or not. And so what we really need to better understand is how often that is happening. How often does it happen that someone that doesn't have symptoms and never has symptoms transmits further? How important is it that someone just before they develop symptoms passes to someone else? And we know that is important. And how does that affect our control measures? The other thing that we spoke we need to spend much more time talking about are these events in which transmission occurs. We know that it happens between close contact with people, when they're within 1 meter of one another, when you have prolonged contact, when that means more than just in passing. And we're quite alarmed by a number of super spreading events that are happening in a large number of different types of controlled, closed settings. So, for example, we've seen outbreaks in long-term living facilities. We've seen outbreaks in healthcare facilities. We've seen some clustering events in mass gatherings, in different types of religious events, in meat processing plants, in expatriate dorms. There's a number of settings where we need to do much more detailed analyses to really understand why and how transmission is occurring so that we can prevent this from happening going forward. And then just briefly on the wastewater. So this is an area of interest that we are looking at and that a number of countries are looking at to potentially look at testing of wastewater for the SARS-CoV-2 virus to see if that could be a sentinel signal for whether or not the virus is circulating. There are some papers that have come out recently, and we are aware of those papers. We've actually reached out to a number of those authors to get more details. Some of those are in preprint, which means they have not gone through peer review. And so we've reached out to those authors to really understand how they've conducted those studies and what those can inform us going forward. Benedetta, I don't know if you want to add anything about, okay.
Okay, thank you, Maria. We will now move to Kai Kopperschmidt from Science. Kai, can you hear me?
Yes, thank you very much for taking my question. This one's probably for Anna Maria. I just wanted to ask whether there's any news on, first of all, the lopinavir-ritonavir arm of the Solidarity trial, given the results from recovery, and any discussion of how to move forward with, now that recruitment is going well, how to move forward, prioritizing the next drugs to test.
I think Anna Maria will respond. Thank you.
Thank you, Kai. So first on the Solidarity trial, we are very pleased with and we're very grateful to all the researchers from the 31 countries who have now approvals for participation in the Solidarity trial. So they have the National Regulatory Authority approval and the Ethics Review approval. Of those, 21 are already randomizing hospitalized COVID patients in nearly 400 hospitals. And we have a global network of above 1,300 clinicians. So we are active in the 6 WHO regions. We are very pleased about that because that gives clinicians and researchers from all around the world the opportunity to contribute to the Solidarity trial. We are also very pleased with the increase in the recruitment rates. So we are now getting to 5,500 patients included in the trial. And unfortunately, we have high rates of transmission, but the good thing, and this was discussed during the forum and encouraged by several of the speakers, is that given that the virus is moving around the planet and that the rates of transmission are uncertain, it is very important to use global platforms like the Solidarity trial to be able to evaluate not only therapeutics but also vaccines, because that will allow us to have the therapeutics and the clinicians in the places where the incidence rate is high at the time of introduction. In terms of the results, there were 2 presentations on the data that is available because it was important for the community to learn what we have learned from the therapeutics that have been evaluated so far. As you probably know, there are nearly 1,700 clinical trials that are registered. Unfortunately, the majority of these trials never started. They started and were canceled or recruited only a few hundred patients. So in total, there was an independent review that suggested that the three major trials contributing to the evidence for hydroxychloroquine, lopinavir, ritonavir, and the steroids, including dexamethasone, were the recovery trial from the UK, the active trials from the NIH, NIID, and the Solidarity trial led by WHO. Of this, there was a discussion of the preliminary results of these trials that suggest and confirm that hydroxychloroquine unfortunately doesn't have the positive effect that we were hoping on mortality for COVID patients. There were also discussions on the potential effect of lopinavir, and the preliminary data suggests that this effect is not there, but we are looking at the analysis. And then there was the discussions on how to look into the steroids. So the recovery trial results that are publicly available were again discussed, and WHO put forward a proposition for a full systematic review of the data on remdesivir and on steroids that will be shortly shared with the community, because we value and we think it's important for all of us to look at the integrated, critically appraised evidence. Thank you.
Thank you, Anna Maria. I will take now a question from Bayram Altuk from Anadolu Agency. Bayram, can you hear me?
Yeah, I can hear you. Thank you so much for taking my question.
Yeah, go ahead.
Can you hear me?
Yes, perfectly, Bayram. Go ahead, please.
Mr. Ghebreyesus yesterday stated that 60% of all cases so far have been reported just in the past month. And United States daily novel coronavirus cases jumped by more than 50,000 for the first time yesterday. On the other hand, while the number of cases increases rapidly across the globe, the mortality rate drops significantly. My question is, so can we say that the COVID-19 is losing potency as it spreads more, or what we know or what we don't know? Thank you.
Thank you, Bayram. Maria or Sumya?
So I think it's we have to be very careful when we talk about mortality rates. Because it's calculated in different ways by different countries and at different times. Case fatality rate is, you have the number of people who die divided by the number of people who have infection, but then the disease, the diagnosed disease, but you also know that there's a gap between somebody getting the infection progressing and then dying usually 2 or 3 weeks later, unfortunately, if that happens. And so it also depends on what denominator you take when you calculate case fatality rate. And it's been suggested by scientists that really to get an accurate idea of case fatality rate, you should divide by the number of cases 2 weeks ago, not the number of cases today. There's also infection fatality rate, and there was some discussion on that during this forum. That probably gives you a better idea of the actual mortality. So the number of people who are infected in the community. Now this number is not often known because what you know is who gets tested, and those are only those who get really sick or those who are able to access testing. So when in places where these seroprevalence studies have been done to look at the prevalence of antibodies in that population, it's clear that the number of people infected often is about 10 times the number of people who actually get diagnosed as cases, which is what gets counted. And so if you look at infection fatality rates, then that is a much lower number, and the figure that was presented was an average of about 0.6%. So that's much lower than the case fatality rates of 5, 6, 7% that we've been talking about. But again, this depends, again, pooling all the data that's still coming in from studies on the seroprevalence in communities will give us a better idea. But the bottom line is that there is a significant proportion of people who die, even if it's 0.7 or 1%, that's still high, and that it disproportionately affects people with certain risk underlying conditions, including obesity in young people. We have to remember the young people are not immune from severe disease or death. It's less common than in older people, but we should not become complacent that it's fine for young people to get infected, because there is a subset, particularly those with obesity, those with habits like smoking, for example, who are at higher risk of complications and death. So I think when we talk about death rates and mortality and we start comparing, it's really important to really look at how that's being calculated and before we do comparisons. The other thing we've seen is many countries have been able to update their death counts later, so it's not on a real-time basis. And but even in high-income countries, and certainly in the low and middle-income countries, the death reporting is not real-time. It takes time to catch up, particularly when people die at home in the rural areas. There's often incomplete cause of death reporting. So we have to keep all of those things in mind when we talk about case fatality rates, and especially when we start comparing between countries or between regions. So you want to add anything, Maria?
Thank you, Sumya. That articulated very well the challenges of estimating and comparing mortality. And as you've said, it's very difficult. It's a very difficult thing to calculate. I wanted to touch upon the question around the potency of the virus and the questions. We've received that question quite often, is the virus changing? And you mentioned the mutations, the changes. These are natural changes that we're seeing in an RNA virus, changes that we expect. And there's a large group of scientists that are part of this group that are looking at these viruses very, very carefully and looking at what these changes actually mean. We have not seen any indication that the changes, these mutations, these changes, confer any difference in terms of transmissibility and severity. But it is something that we are very carefully watching. And it's not just a matter of comparing the sequences themselves, but more work needs to be done to really understand the viruses and what these changes mean, if anything. And so I think that's just an important thing to add. And then just to mention on the serology, because this is part of the core work that we do within the EPI working group. And again, given we're 6 months in, it's pretty astounding that we have seroepidemiologic studies that are underway. And WHO is working in a number of areas with our partners in 3 different areas on serology. The first is to evaluate the serologic assays that are currently in development, and working with partners at FIND and other collaborating centers across the globe to look and see how well do these serologic assays perform against real samples. The second area of work is around what we call the Solidarity II collaboration, which is developing assays and having a panel to be able to develop a standardized serologic assay. And we have more than 110 collaborators from 43 countries in this collaboration. The third area of work is what we call our Unity studies, which is WHO has drafted these core generic protocols for 6 different types of studies on healthcare workers or on household studies or on cases and contacts to support countries in conducting seroepidemiologic investigations themselves. And currently we have 45 countries that are actually implementing these studies right now, and we have an additional 34 that are intending to implement them. And so we're building research capacities, we're supporting countries in conducting these so that they can better understand what is the extent of infection for SARS-CoV-2 virus among certain populations to better inform their next steps as they move through this pandemic.
Thank you, Maria. I think we will take the last 2 questions. One from Tomo Deguchi from Kyodo News. Tomo, can you hear me?
Yes, can you hear me, Fadela?
Yes, perfectly. Go ahead.
Short question on the participants. I believe in February meeting we had experts or officials from Taiwan, but was this the case this time as well? Thank you so much.
Thank you for this question. As Dr. Swaminathan mentioned, the forum was open to researchers all around the world. We circulated an open registration tool in which experts, regardless of whether or not they were in our list of experts, could register. This is how we have experts from all around the world, and we know that there were some of the experts participating actually were from Taiwan. Again, Dr. Swaminathan insisted we make a big effort to have experts from all around the world, and they could on their own register. It was open to all researchers.
Thank you, Anna Maria. We will take maybe the last question from Ellen Branswell. Ellen, can you hear me?
Yes, thanks very much for taking my question. It's for Anna Maria, please. Anna Maria, is anybody in phase 3? And if I can sneak in something else in terms of vaccine, did you hear anything that relates to the question of whether or not any of these vaccines are inducing, if there's any risk of vaccine-enhanced disease associated with any of these vaccine candidates? Thank you.
Thank you, Helen. The theoretical risk of enhanced disease has been the object of extensive discussion in our expert groups, and also in the expert groups by other collaborators. Indeed, all the protocols that were presented, or the majority of them, has the potential to evaluate enhanced disease. I just want to explain there are 3 levels of the evaluation. First is during the preclinical phase. So there are ongoing efforts to try to establish animal models that will allow us to evaluate enhanced disease in animal models. That has been accepted as a potential way to evaluate, but it's not sufficient. In addition to that, you have to start by going through the clinical evaluation phase and evaluate it in humans. The most important part of the clinical trials to be able to document enhanced disease is to have longer-term follow-ups. And most of the trials that are being planned include 12, 15, and 2 years follow-up. And in addition, it has been clearly identified that there is the importance of post-marketing surveillance of safety as an additional element to document enhanced disease. So most of the sponsors or potential sponsors, developers, and researchers are fully aware of the importance, and the majority of them are making provisions in the protocols for the phase 2b/3 trials, for longer-term follow-up, for measures to document information from vaccinees in hospitals, etc., so that this can be ascertained. And I insist, it remains a theoretical challenge, a theoretical possibility, but is well considered by all.
Thank you, Anna Maria. I think we will stop here for today. It has been a long day for everyone. Thank you for your interest. And I don't know if one of my colleagues want to say final words. If not, we will conclude this press conference. Maybe Soumya, final words?
Yeah, maybe just as final words. I mean, we did also have some discussion on the transmission from human to animals. This may be of interest to some people, and it's clear that there are some animals like the felines, the cats and the ferrets and even tigers that can get infections. So human to animal, but very little evidence of the reverse, and also interesting data presented on the virus and how long it can survive on the fur of animals and so on. So there's very little risk from domestic animals, because there was some concern and about domestic animals becoming a source of infection. However, you would have seen the reports of minks in mink farms actually getting the infection and even perhaps being able to transmit it to humans. So this is again an active area of research. As I mentioned, the animal-human interface, and it was a robust discussion because, of course, it's relevant not just for this outbreak, but also for the prevention of future pandemics. And so the whole issue of how does one not only have surveillance for these emerging viruses that can cross the barrier, but also surveillance among different species of animals to see what viruses are circulating, and importantly also to think about how markets that deal with meat and food need to be regulated. What are the minimum hygiene standards that need to be put in place, and also the illegal trade of wildlife, which can actually aggravate some of these conditions. So that whole area of research, the One Health, where the group actually has people from FAO and OIE, in addition to scientists from around the world, was also one of the areas that was discussed. So overall, I think we had, as I said, in a limited time, covered a huge array of topics, and were able to get glimpses into what's going on in these different areas. But we will probably follow up with more in-depth interactions with the scientists within the working groups, and perhaps also between working groups, the interdisciplinary work that was very much encouraged and welcomed by the participants in order to take all these areas of work forward. And we're happy that WHO has been able to bring together scientists from around the world to collaborate, but also to accelerate, I think, the science. And our goal is to see that the learnings from science are as quickly as possible channeled into impact for patients and communities. That's the goal of this research. It's not an academic exercise. It's how do you take the learnings, put it into interventions, either in clinical or in public health, so that it starts, we start seeing an impact on the pandemic. And that's why WHO is so involved in this and key to try to make this happen in the best way possible. Thank you very much for all of you for having come and for those excellent questions that you had today.
Thank you for your attendance, journalists as well as our colleagues from WHO. As usual, we will be sending you the full audio file, and the transcript will be available as of tomorrow on the WHO website. So see you next time, and have a nice evening. Thank you. Bye.